Good morning. My name is Peggy Miles, and as you've already heard, I'm a member of the Board of Directors at Cedars-Sinai and currently Chief of Staff. I'm delighted this morning to introduce our next speaker. I think more important than my leadership positions at Cedars is the fact that I'm a faculty member in general internal medicine at Cedars, and I regularly serve as the attending physician for many of the kinds of patients that inspired this conference. You may be surprised to learn that Cedars-Sinai provides care to one of the largest percentage of Medi-Cal and the largest percentage of Medicare patients in California. For Medicare patients over the age of 85, we have the largest percentage of any university hospital in the state and in the nation. We perform more heart transplants than any other center in the world, which means that we care for many complicated heart failure patients. Our cancer population is larger than that of UCLA and the City of Hope combined. And it's a regular occurrence that the patients whose care I oversee are frequently frail, elderly, and have many complex medical conditions, all of which make end-of-life discussions a very common occurrence. Personally, I too have struggled with many of these same difficult decisions. When my father became ill, and more recently, as my 86-year-old mother's health has begun to deteriorate. Much of what we're doing here today reflects the vital necessity that those who work in healthcare policy, be it at the local, state, or national level, be well informed about the actual experiences that we face every day in the clinical world, and that good policy must be reflective of clinical reality. That means that at the center of our concern and our attention, we must remember the patients, their families, and their loved ones. It's to that voice, the voice of the patient and their loved ones, that we now turn. Please welcome Elizabeth Bailey, a patient advocate and the author of the Patient's Checklist, 10 simple checklists to keep you safe, sane, and organized. Hailed by the New York Times as a godsend, and I tell you, I wish all of my patients had this book. It's really so simply put together and eloquent, thank you, and helps patients prepare for their hospitalizations and their journey through healthcare. Prior to her late career shift, and I think that's very unfair, also as you look at her, it doesn't look like she's had a late career, she's late in her career at all. To advocacy work, she was a producer, director, and vice president of music video production for several record labels. Her father's catastrophic run-in with our healthcare system inspired her switch in careers. She earned her master's degree in health advocacy at Sarah Lawrence College and has had extensive experience working as an in-hospital patient advocate. She's currently working on 3 new projects: a documentary film exploring ways to demystify palliative care for the layperson, a follow-up book to help the sandwich generation of caregivers, I put myself in that category, negotiate long-term, complex caregiving, and also a new Instagram. So she's in the modern world as well. Humans of Palliative Care, which she's developing with the California Coalition of Compassionate Care. This morning, she's going to share with us some of her experiences as the primary caregiver for her father during the final months of his life, and challenge us to keep the voice of the patient's experience as primary for our work ahead. I'm truly delighted to welcome Elizabeth Bailey to the podium.
Hi, everyone. I'm honored to be here today, and I would like to thank Stuart Finder for inviting me. As Peggy said, I am Elizabeth Bailey. I did receive my master's in health advocacy at Sarah Lawrence College, and I did write the book, The Patient's Checklist. The book is a common sense roadmap for patients and families written in plain language who find themselves suddenly trying to navigate a hospital stay. What prompted me to switch careers, moving from the film and music industry to patient advocacy and to write this book, is what I want to share with you today. My experience as the primary day-to-day caregiver for my father who died this past August. My sisters and I were caregivers to our father for over a decade. 3 months ago, my 91-year-old father died after a 6-week hospitalization after a fall in his apartment in New York City. My hope is that my story, my father's story, and my family's story, which I will share with you this morning, will bring into clearer focus what patients and their families actually undergo as they confront and navigate serious illness, decline, frailty, and the process of dying, and ultimately the death experience itself. While my experience is particular to me and my family, I think it is safe to say that all family caregivers realize some fundamental truths. First, modern medical care makes it hard to trust your intuition and common sense, the internal GPS that most of us rely on throughout the course of our lives. This intuition and common sense is based on the lived life of the patient and family, and it is subjective, humanistic, and qualitative in nature. And even if this can get lost in the high-tech hospital setting, this is always at the core of what matters to the family and underlines their perceptions of quality care. We think, we dream, we hope in everyday language. Patients value interaction. Technology is always peripheral. Second, and this is always true, patients and families don't know what they don't know. And third, the family's experience at the end of life recalls, at least for me, the famous quote from Ernest Hemingway's The Sun Also Rises, when Mike Campbell is asked how he went bankrupt, and he replies, 2 ways, gradually and then suddenly. This is an apt description for how families are ill-prepared for both the relentless and yet often ad hoc and chaotic nature of long-term caregiving and the death of a loved one. And as I get older and older, I realize this is really a description of how all of us experience the passage of time in our own lives. It catches up with us out of the blue. However, over the long decade of caring for my father, I went from being one of the 43 million unpaid, exhausted family caregivers to a daughter filled with gratitude for the care my father and my family received from all the physicians, nurses, aides, social workers, therapists, and chaplains during the last 6 weeks of his life. They cared for all of us. And to have no regrets at this critical time was a profound gift. Yet it was truly a 10-year journey of caregiving punctuated by many abrupt twists and turns, and it was exhausting and often harrowing. As one of those not-so-rare native New Yorkers who has never learned how to drive, strange but true, I know, in California, it often felt like I was stuck behind the driving wheel, hurtling down Mulholland Drive without a trusty driving instructor with nerves of steel by my side. My hope is that by sharing my experience, reflections, and insights on that steep, steep learning curve, it might be of service in improving end-of-life care for other families and patients and for all of you. So I will begin at the beginning, which I call Part 1, the catastrophic and unplanned event. This can often be the moment where patient and families really first come face to face with the modern medical industrial complex, with all of its amazing high-tech interventions, but also hyper-specialized fragmented care. Collectively, we recognize that there are problems with our healthcare system, and we want to see them solved. But my role today is not to address policy or structural issues, but the experiential issues families grapple with during these times. 10 years ago, my dad, at 81, was still practicing law. He still lived in the same Greenwich Village apartment that he and my mother moved into 55 years ago. He was a widower. My mother had died a decade prior from pancreatic cancer. He had a wide circle of friends. He traveled. He read voraciously, and he relished digging into the New York Times every morning and reading it cover to cover. And he mixed a very mean gin martini. Late in the summer of 2006, my father suddenly developed double vision. He had no health issues except for mild type 2 diabetes that he controlled with his diet. His first appointment was with a well-known eye specialist who was concerned my father might have had an issue with his temporal artery. My father's default response was to not see his internist, but to see the specialists. A biopsy was scheduled, and my father was given a prescription for prednisone, 100 milligrams a day, as a prophylactic to begin immediately. Even though the pharmacist questioned the dosage and asked my father to check with his physician, my father did not want to seem like he was second-guessing an expert. The biopsy proved negative, but my father's vaguely written discharge instructions said to continue all pre-op medications. As the prednisone was the only thing he was taking, he continued to take it. And for whatever reason, he had a refill, go figure, which he filled. At the time, none of us realized he was still taking this medication. It is at this point, whenever I'm telling this story to a doctor friend, that he or she invariably asks me, "And how long before your father went crazy?" Not long. In short order, my father landed in the ER of one of the best hospitals in New York City. But no matter how great an institution, as a family, we were thrust into a completely foreign universe with its own highly specialized culture and language. It was sudden and extreme, and we simply did not understand what was going on. Since the day my father was shipped out of the Pacific as a teenage Marine after the invasion of Guam to a hospital in Hawaii, he had never in his adult life spent a day in the hospital. But hospitalized he was, with coma-inducing blood sugar levels and full-blown steroid-induced psychosis. The ER doctors surmised that it was probably slowly rising blood sugar levels from his diabetes, which had caused his double vision. And in fact, once his blood sugar was brought under control, his double vision disappeared. But his psychosis took much, much longer to treat. My father was hospitalized for over a month, and it was a rude awakening for me to realize how unmanageable fragmented care is for any family. It is just so hard to get a hold of, to make sense of what is happening. And we thought as a family we had the time, education, and resources to navigate his hospital stay. We were wrong. If my father had been hospitalized for only a few days, I might not have noticed the full effects of his fragmented care. Multiple specialists, information vacuums, miscommunications. But because he was hospitalized for over a month, I became, so to speak, somewhat like an embedded journalist, and necessity demanded that I figure out some kind of system to manage his care in all its aspects. I had to translate it into everyday terms. Who were his doctors? When did they round? What were his pills? When were they given to him? What do they look like? Why is he taking them? Who are his nurses and aides? And when do shifts change? I essentially had to translate the culture and language of medicine and hospital care to regular life. And this is where I brought in my film experience as a producer. I fundamentally started producing our way out of the hospital because when I was in my hospital, when I was in my dad's hospital room, at a certain point I was like, this is the worst run film set I've ever been on. So, and I used checklists in production, and I was used to working, I was the producer, I was the lay person on production. I worked with highly specialized people, the cinematographer, the lighting designer, the production designer, the costume designer, and I didn't have to know how they were developing the film or what temperature or what lenses they needed to use. I just needed to make sure that everything was there and we were all working on the same page. And so I started thinking about that in terms of dealing with my dad's 8 different doctors and nurses and all the other people that come and go that you're not really even sure of, why they're coming into the room. Eventually my dad was discharged, cured perhaps, but not healed. While my father was discharged after this first hospitalization and sent home, he was never completely whole again. This first horrific health crisis set in motion years of decline, punctuated by one hospitalization after another. It took months for him to recover from the after effects of the steroids, which necessitated round-the-clock aids. His medication cost us thousands of dollars. And while he was discharged, he still needed caregiving, and we really had to make it up as we went along. I call this time, the majority of the 10 years we took care of him, our years in the wilderness. My sisters and I became card-carrying members of the sandwich generation, juggling our own families, our careers, and our dad's needs, which only increased over time. We had to learn to grapple with a healthcare system set up for rescue care, not the social services my father needed to be cared for at home. And few Americans have the resources for long-term home-based care. My father might have practiced law for over 40 years, but he was a solo practitioner responsible for his own retirement fund, and that fund disappeared pretty quickly. For the last several years of his life, my sisters and I supported him entirely, except for his monthly Social Security check, which did not even cover the monthly rent for his rent-stabilized apartment. Besides the financial strain, these years were marked by increasing social isolation for my father as his friends died off, and for me as his day-to-day care needs increased and his mobility decreased as he moved from cane to walker to wheelchair. In these in-between years, we as most older children caring for older parents have a host of issues and concerns of our own. Children, spouses, school, our own health needs, those in particular are always put on the back burner. Caregiving affects the entire family unit. At the same time, my personal caregiving experience began to become intertwined with my new professional experience, from getting my master's in health advocacy to working as a part-time in-hospital patient advocate for several years. I came to know what I didn't know. My experiences working with families in the hospital informed issues I grappled with for my father and vice versa. If holding the hand of a lonely and frightened patient in the hospital offered comfort, it also offered comfort to my dad at home. My interest in palliative care began to take center stage in the ways I began to manage my father's health. And finally, after burning through resources, we reluctantly turned to the VA, the much maligned VA, for medical care and whatever social interventions we could get for the few years of his life. And bringing my father into the VA fold provided practical benefits I had not foreseen, but made a huge difference to us. All physicians, and all the physicians were great, under one umbrella and essentially at one hospital. One set of electronic medical records so everyone could communicate with each other. Easy access to my dad's medical records and an easy email system to communicate with his care team. While these practical structural fixes did not make caring for my dad less time-consuming, they definitely made it much less stressful. And lastly, the final 6 weeks of my father's life began the way it does for so many frail elderly, with a calamitous fall. My father had just finished what was to be his last gin martini, and he fell in his living room. Because he stubbornly refused to wear any sort of help me I've fallen device, it took him over 3 hours to crawl to the phone and call for an ambulance. In what proved to be his final 6 weeks that I was able to integrate what I now know that I know. In some ways, it was 2 simple steps. We asked for a palliative care consult early on because my dad was in such pain, and we asked for a family meeting, which became regular family meetings over the final weeks of his life. By asking for a palliative care consult early on, which I only learned from professional experience in the hospital, what that was, this made the question, what is important to you, at the center of my father's care. It created a space where moral, not simply technical issues began to guide his care. What is important to you shifts the central act of caregiving to listening, and by extension, it shifts the relationship between doctor and patient to one that is a more equitable partnership, because it privileges plain language and lay expertise. End-of-life care would be so much easier if palliative care was moved further upstream in the care continuum. These conversations would be the backbone of caring for any patient at any stage of a serious illness, whether life-threatening or not, because patients and families could talk in the language that they live in. We all know that good end-of-life care must integrate the patient's story, which means really a shift from focusing on primarily the patient's complaint, symptoms, the physical, the measurable, the objective, to the patient's concern, which are subjective, humanistic, and holistic. End-of-life care is unscripted, it's improvised, it is moment to moment for families and patients. But because we had asked for the palliative care team to be involved, and we had regular family meetings, we could make decisions based on the question that started every conversation with my father. Mr. Bailey, what is important to you? And for a while, my father, Louis Davenport Bailey, could tell his doctors that that meant the New York Times, 2 bowls of ice cream a day, an evening martini if that was possible, and, oh yes, his daughters and his pesky grandkids. But sadly, my dad shared the fate of so many other frail elderly, and the longer he was in the hospital, he succumbed to various complications, deconditioning, delirium, pressure sores, and the like. But my dad was able to have clear conversations with his doctors where he told them he wasn't afraid to die. One day, a chaplain popped into his room. My dad was a fervent atheist, and when I was around, I sort of discouraged those interactions. But this day, I wasn't there at that moment. And the chaplain began to ask my dad about a photograph of my mother and father that was on his hospital tray. And it was my dad's favorite photo of them. At the time, my dad was really going in and out of lucidity, but these two talked for over 20 minutes. Later, his nurse told me that when the chaplain came out of my dad's room, he said to her, "They don't make love like that anymore." That was a moment and a gift for us. It was around this time that my father really began to eat and drink less and less. At this point, a decision was made to move him to hospice. We wanted to move him home, but we could not move him home because we didn't have the resources for round-the-clock nursing care, and my dad was beyond the point of even a 2-person cyst and needed a lift. But even here, I had to really advocate and agitate for him to be transferred to the VA's new palliative care unit, because his prognosis was surprisingly optimistic, that he could live 6 months or longer. And the palliative care unit would only take and consider patients with 3 months or less to live. There was no way my dad was going to live 3 months. And I am forever grateful to the social worker and the palliative care doctor at the main VA campus who pushed and pulled strings for my dad to be accepted. And my dad only lived for 2 weeks after his transfer to this PAL care unit. Sorry about this. But it was here, in this palliative care unit, that I understood what making a place for the patient and family could be like. And it was centered on communication around the central question, what is important to you? But at this point, that included us as well. It was the little things that accumulated that made the difference for us, the small acts of kindness. From the greeting when my dad was first wheeled into his hospital room, "Thank you for your service to our country, Mr. Bailey. We are proud to take care of you." To preserving his identity and dignity by dressing him daily in his own clothes, no easy feat. And encouraging us to personalize his room with photos, books, and the radio turned to NPR. The nurses, social workers, physicians, and especially the personal care aides took care of all of us as much as our father, always asking us if they could get us a tray of hospital food, thanks but no thanks, or a pillow, yes please. Each room was an individual room with 2 sleeper chairs and an assortment of other chairs, an acknowledgement that at this moment in this person's life and dying, the family, if given the chance, does the bulk of round-the-clock comfort caregiving. There was a robust volunteer service to tend to soldiers who might not have family, and they integrated complementary modalities like Reiki for patients and family members. There was quiet and peace, which made a place for acceptance. We were able to truly be present and to live in the moment, and these moments of grace multiplied. And when my father died, after they prepared his body and draped it in an American flag, a soldier came to play taps as they wheeled his body down the hall, and everyone saluted. After my father's death, the follow-up from the VA was not an HCAP survey, but questions about our perceptions, our experience of our father's care. It made us central to good care. It made us feel that our concerns mattered. So I think if the question, what is important to you, becomes the hallmark of good care at any time, but especially at the end of life for patients and families, it also creates a space for that to become the central question for you as providers and institutions as well. It makes active listening a learned skill central to good care. By continually asking and being guided by what is important to you, my dad was able to die as the person he was in life. And for that, I am filled with gratitude. Thank you. I took a few acting classes before this, so I wouldn't cry, but it didn't work. So now I'm opening it up. I'm regaining my composure. I didn't think that was going to happen, actually. So I'm opening it up for questions or comments, if there are any.
Do you wish you had started at the VA sooner in his trajectory?
Yeah, I did. I do. But I think that my dad was also the first several years after after that first incident, we were in that place where we were just seeing so many different specialists at so many different hospitals. And my father was, sort of, he was bothered by certain things, and so he wanted to see neurologists and eye doctors, and he also didn't want to give up some of his physicians that he had been going to. But honestly, and I was also afraid to go to the VA. We sort of thought of it as the default, but it was really amazing. And structurally, it was so easy for us, too, and that makes a huge difference. I always felt that we were all on the same page, and I had such easy access to his records and could email his nurses and physicians, and he was seeing multiple doctors within that VA hospital, too. So they were great.
Deborah Greenspan, Hospice and Palliative Nurses Association, Los Angeles Regional Chapter, and State Ambassador. I'm also a Reiki Master and a hospice triage nurse. Do you have any plans on how to move this conversation forward so that we don't have to advocate so hard for our patients and families to access care, palliative care at the VA and other hospitals, so that they're not prognosticating 1 year or more when we have 2 weeks or 6 months to live? Thank you.
When I worked at the hospital as an inpatient advocate, I often suggested to them, and I really do think that this is true, as an advocate, my primary role was to facilitate communication, and I was called in either by the family or, more often than not, a nurse manager or a physician if there was some issue or problem or misunderstanding. And I often felt that patient advocates can play a more vital role in the hospital setting, in that they're the lay person and they are the advocate for the patient. At least this was the situation when I originally started at this one particular hospital. I think that they got tamped down a little bit by HCAP surveys and the like. Their role sort of diminished a little bit. But I think that hospitals could really honestly start having peer-to-peer learning sessions in their auditorium for family members, where it could be an advocate perhaps and a social worker, and maybe it's once a week or maybe it's twice a week, but families can come and learn about different things. I mean, I think about this often because I inherited hearing issues from my grandmother. Thank you very much. And I wear hearing aids, and my audiologist last year asked me to participate in a group where people, and I was actually the youngest person in the group, but people were trialing different hearing aids. And so there were 10 of us in this group, and I was really astonished that most of the people had hearing aids that they didn't wear, or they were unhappy with, or they couldn't figure out. But once we were all together talking about it, like, okay, how do you stop the whistling? Or do you feel like you can hear whispers, or can you hear children's voices? When we were sort of talking about it, not as decibel levels or high frequency drop off, that it really helped people understand and actually figure out how to use their hearing aids. And I make that jump and think that there is a way to help families on a continual basis in the hospital setting. I think that there could be regular workshops, and I think it would only help the frontline providers too, because I felt that when my dad was in the VA, it wasn't as if in the palliative care unit, he didn't get more care from the physicians and nurses and social workers than he got in the regular hospital, but we got more support to offer him comfort care on a round-the-clock basis, and we did. We spent the night, we were there, we were the ones holding his hands, but we also felt like we weren't alone. And I think that although I know we always wanted our dad, and my dad always wanted to die at home, but the practical reality of that is sometimes that's magical thinking. By the time my dad moved to hospice, the idea of bringing him home was terrifying to us. I mean, we just didn't really know what to do, and we also, frankly, couldn't afford it, because also his prognosis was, it was going to go on endlessly, and in fact, he only lived for 2 more weeks. So I hope that answered. That's long-winded, a bit long-winded, but I hope that answered the question.
Muriel Dance, a recently retired hospice chaplain. I too just lost my dad recently, and what I really heard, because it happened for him as well, they started with specialists. I kept saying, have you talked with the internist? The specialist recommended surgery for my 92-year-old father. So I think we have to hear that we as families have a role to remind people to say, have you started with your GP, your internist? Thank you.
Hi, I'm Ulema, social worker at Kaiser West LA, but I'm also a caregiver for my parents and my brother who's developmentally disabled. So I'm just curious on a professional and personal perspective, how did you deal with, before you enhance your skills as a patient advocate, with other providers or clinicians when they're like, oh, here comes that daughter, oh, kind of like, how did you address that, or what do you advise patients or families? Because I think I've dealt with it personally, and then I'm the professional, like you already know who it is, but how do you interface that to make it a more positive and collaborative relationship?
Well, I can say, I think my past professional experience, having to sort of coax Rod Stewart out of his dressing room, or get the guys in Metallica to not be arguing about who had more close-ups in the video or whatever, that I had to learn a certain diplomacy as a producer, because I had to get them to do actually what the director wanted them to do. And so I think I had a little bit thicker skin about being the crazy daughter. But I will say that once I worked as an inpatient hospital advocate, I really saw the other side. And one day, for instance, I was called by the practice manager of the outpatient surgical clinic, which to come because a young resident was refusing to see a new patient, and it was a Friday afternoon. And she called me, and she was really mad at the physician, and I went to talk to him, and I went, and the clinic is really for the poor patients and the Medicaid patients. And the son had brought his mother in, and he had to take off a day from work, and they had traveled on the subway for 2 hours to get there. And I was sort of outraged, like, why isn't this resident seeing this patient? And I went to talk to the resident, and I said, you know, what's going on? And he told me that he basically was alone on a Friday, and he had 70 patients to see, most of whom he had never met before. And so the idea that he was going to cycle through all these patients, he was more concerned because her situation was so serious that he didn't have the time to deal with the family's questions. But of course, the son couldn't keep taking time off from his minimum wage job to keep coming back in to see, you know, to see the clinic and get his mother care. And so when I had that interaction with him, as well as having interactions with other physicians, I saw what they were up against. And yes, it gave me insight so that I didn't generally approach, you know, physicians who were dealing with my father as the, you know, crazy harridan, but because I tried to understand where they were coming from too. Because if I didn't do that, then they weren't going to understand where I was coming from, is what I really felt in the end. So.
Hi, I'm Tony Loffredo. I'm an ER doctor at Cedars. Really amazing, this talk you gave us.
Thanks.
You mentioned that everything seemed to change for the better when palliative care got involved. I'm just wondering, do you think they were involved early enough, and could it have been even better if they were earlier?
I think probably it would have made things better for us, because I also think you know, what happens with the palliative care team is that they also, you know, it's very family-centric. And so they're also dealing with our anxieties as a family and our sense of, you know, what's going on and or what to do. And there really is, you really do feel like when you're caregiving for an older parent that you are in the wilderness. You're trying to manage all this stuff, and you don't just want to keep going back to the emergency room, but that's sort of what you wind up doing over and over and over again. And I think probably the quality of his quality of life might have been better the last couple of years, and we might have understood things a little bit more. I also think my dad was a realist, and you know, he really wasn't afraid to die. And he really, as his life kind of narrowed, he was very lonely, even though he had his family around. He didn't have his friends around, and it became a very solitary existence. But I do think the difference, which I wish I had done at other hospitalizations, is, you know, the first day I asked for a palliative care team to come and do a consult. And that made a huge difference. And also, really, it made a huge difference for the young resident who was his primary physician, because that resident who was not on the pal care team, but was just on that particular unit, was involved in every palliative care discussion, and he grew very close to our family. And I feel like he had an education in taking care of, you know, hands-on education of taking care of, you know, my dad, an elderly geriatric patient, and he was our go-to person to call. I didn't call the head of the palliative care division. I talked to Dr. Talcott, and, you know, I think, you know, at the end when my dad was transferred, he was teary-eyed. And I think, because he had been caring for my dad for 4 weeks, but I think he got an invaluable education. And I think that that's one of the ways other physicians can be educated, is just if they're willing to invite the pal care team in, or if a patient advocate suggests it to a family, because it's really basically about support. I mean, it's really basically about what we as lay people think good doctoring is. And then we realize that that isn't part of the equation unless we ask for it.
One last question.
Okay.
Hi, my name is Jessica Coltman. I'm a primary care physician and health services research fellow. I really appreciate your analogy to producing and coordination of care. What I found during my residency training is that there was a lot of specialists going to see the patient, giving them a lot of different messages about treatment and prognosis, and it really confused the family. And I was wondering, what lessons do you think the medical profession can learn from producing and sort of the other side of the world in terms of how we communicate and how we work as a team?
Well, that's an interesting question because, you know, I mean, sort of an analogy of that is, for instance, when I was producing and the director and the cinematographer wanted, let's say, the lighting and the set to look a certain way, but the musician didn't really understand, they would bring in tear sheets, you know, so there was like there was no language, you know, it was visual aids. And I definitely just think that this idea that a family is really capable of handling production because they know this person, they know the baseline, they know what this person is in their life before and perhaps, you know, life after a hospitalization. And so I just think really it's about talking in plain language, you know, I really do. So anyways, thank you, everyone.